Welcome. We're doing a focused deep dive today on facial reanimation, really honing in on what you need for board exams like the FRCS.
Exactly. It's a complex area, especially the facial nerve anatomy itself. So a structured approach is key.
Right. Our mission here is to distill those essential concepts, practical knowledge, differentials, everything vital for exam prep. Let's start with the foundation, facial nerve anatomy.
Okay. So functionally, you need to know the four components. First, the branchial motor. This controls your muscles of facial expression, think smiling, frowning, plus stylohyoid, stapedius, posterior billy of digastric.
So all the main movements, what's next?
Second is visceral motor. That's the parasympathetic supply. Lacrimal gland for tears, submandibular, sublingual glands for saliva, nasal mucosa too.
And there are sensory roles as well, correct?
Precisely. Third, general sensory. That's sensation from parts of the ear, the concha, external canal, even the eardrum.
Okay.
And fourth, special sensory. That's taste, specifically the anterior two-thirds of the tongue. Understanding these roles helps pinpoint where damage might be.
That's a very clear functional breakdown. Now let's trace the nerve's actual path, the physical journey.
Sure, we break it down into three main segments. Intracranial, inside the skull, then intratemporal, running through the temporal bone, and finally extratemporal, once it's outside the skull.
Starting with intracranial, where does it originate?
Well, the motor signals start high up in the primary somatomotor cortex, precentral gyrus. But the nerve cell bodies, the facial nucleus itself, is in the dorsolateral pons.
And there's a key point about cortical input here, isn't there?
Yes, absolutely crucial. The neurons supplying the temporal branch, the one for the frontalis muscle, get input from both sides of the cortex. Bilateral input.
Whereas the other branches.
They mostly get contralateral input, just from the opposite side.
And clinically, this matters because...
Because with an ipsilateral supranuclear lesion, say, a stroke above the nucleus on one side, you get contralateral facial weakness, but the frontalis is often spared. That bilateral input protects it. It's a classic finding.
Okay, got it. That distinction is vital. Now, moving into the temporal bone, the intratemporal segment.
Right. The nerve enters the internal auditory canal, initially traveling with the acoustic and vestibular nerves.
A tight space.
Very tight. Then it goes solo through the fallopian canal, which is about 30 millimeters long. And the medial foramen, where it enters this canal, is the narrowest point overall, about 0.68 millimeters, a real bottleneck.
And the fallopian canal itself isn't uniform, is it? It has sections.
Correct. Three parts. First, the labyrinthine segment. It's short, maybe 5-6 millimeters, running to the geniculate ganglion.
The geniculate ganglion, that's where the sensory cell bodies are.
Exactly, for taste and general sensation carried by the nerve. This labyrinthine segment is also the narrowest part within the fallopian canal itself, diameter-wise, and the nerve takes up a huge percentage of the space, like 83%.
Making it vulnerable.
Highly vulnerable. It also gives off the greater petrosal nerve here, parasympathetic to the lacrimal gland, taste from the palate, and crucially, the sharp turn where it meets the next segment.
The tympanic segment.
Yes. That junction is a very common spot for shearing injuries, like in temporal bone fractures.
Okay, so that labyrinthine segment sounds critical. What about the tympanic part?
The tympanic segment runs horizontally, maybe 8-11 millimeter from the geniculate ganglion, until the canal bends again, near the lateral semicircular canal.
And the last part within the bone?
That's the mastoid segment. It descends towards the stylomastoid foramen, where the nerve exits the skull. This part's the widest, 9 to 12 millimeters long.
Does it give off branches here?
Yes, three important ones within the bone. First, the nerve to stapedius motor dampens loud sounds. Interestingly, its origin is outside the main facial nucleus, so it's often unaffected in Mobius syndrome.
Okay, what else?
Second, a sensory branch to the external auditory canal. Reduced sensation here, hypsedentidisia, gives you Hitzelberger sign, which can help localize.
Useful sign. And the third?
The chorda tympani technically arises just infratemporal, but functionally linked here. It joins the lingual nerve, carrying parasympathetics to submandibular and sublingual glands, and that special taste sensation from the anterior two-thirds of the tongue.
Anything else notable about the intratemporal segment before we move out of the skull?
Well, two things. In kids, the nerve diameter relative to the canal is smaller, which might make entrapment less likely. But for surgery, remember, there's no reliable map, no topographic organization of fascicles within the canal. You can't really do selective grafting based on position in there.
Right, that's a key surgical limitation. Okay, let's follow the nerve out, the extratemporal segment.
So it exits the stylomastoid foramen. Initially, it's fairly protected by the mastoid tip, tympanic ring, mandibular ramus.
But more superficial in infants.
Yes. Under 2 years old, definitely more superficial, something to keep in mind. The main trunk then runs anterior to the posterior belly of digastric along the styloid process, heading for the back edge of the parotid gland.
And its depth.
About a centimeter deep, inferior and medial to the tragal pointer. That's your key surgical landmark.
And within the parotid is where it really fans out.
Exactly, the classic arborization.
Yeah.
Usually divide first into superior and inferior divisions, then these split further into the 5 main branches: temporal, zygomatic, buccal, mandibular, and cervical.
Supplying all the different facial muscles.
Correct. There are variations, of course. Some describe a trifurcation pattern, zygomatic often being the biggest, marginal mandibular may be the smallest. Generally, temporal comes off the superior division, cervical and marginal mandibular off the inferior.
Are there connections between these branches?
Oh yes, lots of interconnections, maybe 70–90% of the time between the major divisions, except notably between the frontal temporal branch and the marginal mandibular. Those are less commonly connected.
And where do these branches run relative to fascial layers?
They lie just deep to the SMAS, the superficial musculopondorotic system, but again, no consistent spatial map you can rely on surgically.
Okay, let's zoom in on two particularly critical branches for exam purposes: temporal and marginal mandibular. The temporal first.
The temporal or frontal branch innervates frontalis orbicularis oculi. Its course is fairly predictable, running along Patangi's line from about ½ centimeter below the tragus to 1½ centimeters above the lateral brow.
Location.
It's within the temporoparietal fascia. The superficial temporal artery is often deep to it. It branches out 1 to 5 rami usually as it crosses the zygomatic arch. Lots of cross connections above the arch, but importantly, no connections down to other main facial nerve branches.
Got it. And the marginal mandibular nerve controls the lower lip depressors.
Right. This one has fewer connections to other branches, only about 15% of cases, making it more vulnerable to isolated injury.
Its position relative to the facial artery is key, isn't it?
Yes, and variable. Posterior to the artery, it's usually above the mandible's lower border, maybe 80% of the time. But anterior to the artery, it's pretty much always above the border. It runs superficial to the facial artery and vein.
And injury here leads to...
Weakness of lower lip depression. Clinically, you often see drooling.
Okay. Finally, before differentials, a quick word on the muscles themselves.
Sure. You've got orbicularis oris around the mouth, plus about 23 other paired muscles. They're arranged in 4 layers.
4 layers. Any key innervation pattern?
Interestingly, yes. The deepest layer, layer 4, gets innervated superficially. The muscles in the other layers get innervated from their deep aspect.
Good distinction. And key actions to assess?
Definitely. Frontalis for eyebrow raising, orbicularis oculi for eye closure, zygomaticus major and minor for smiling, grimacing, orbicularis oris for lip pursing, and the lower lip depressors like depressor labii inferioris for positioning the lip during chewing. Knowing the main muscles, their branches, and actions is fundamental.
Absolutely. Okay, that's a solid anatomical foundation. Let's pivot now to the differential diagnosis of facial paralysis. How should we approach this?
Systematically is best. Think anatomically. Intracranial, intertemporal, extratemporal. Also consider unilateral versus bilateral and pediatric cases.
Okay, starting intracranial.
Think vascular events, stroke, CNS degenerative disorders, intracranial tumors, obviously, brain trauma, and congenital issues like agenesis of the nerve.
Right, and moving into the temporal bone, the intratemporal causes.
Infections are big here. Bacterial, viral, cholesteatoma, that skin cyst, can erode the bone. Trauma, again, specifically temporal bone fractures, longitudinal or transverse. Bell's palsy fits here, location-wise. Systemic things like diabetes, HIV can play a role too.
Okay, and outside the skull, extratemporal.
Malignant parotid tumors are a major concern, invading the nerve, penetrating trauma to the face. Primary facial nerve tumors themselves, and other nearby malignancies, mandible, pterygoids, skin that can track along the nerve.
Let's focus on unilateral paralysis now, which is much more common, starting with the most frequent cause.
Bell's palsy, idiopathic acute peripheral palsy. Accounts for, maybe 85% of cases. Incidence is around 15–40 per 100,000 per year, maybe higher in pregnancy.
And crucially, it's a diagnosis of exclusion.
Absolutely. You have to rule out other causes. Red flags that argue against Bell's include simultaneous bilateral palsy, slow progression over more than 3 weeks, slow progression with hyperkinesis or twitching, no return of function at all within 6 months after an abrupt onset, having an associated ipsilateral sixth nerve palsy, so lateral rectus weakness, or having recurrent episodes of unilateral palsy.
What's the suspected cause?
The leading theory is a viral vascular insult, inflammation, swelling, compression of the nerve, especially in that narrow fallopian canal,
Management.
often just observation. Spontaneous recovery is high, maybe 71% complete recovery, usually within 6 months, though it varies. Age and initial severity impact prognosis.
What about medical treatment?
Steroids like prednisone, if started within 24, maybe 72 hours, may improve outcomes in adults based on studies, but importantly, routine steroids aren't usually recommended for kids with Bell's.
And surgery.
Surgical decompression of the nerve, particularly the labyrinthine segment, is controversial, but might be considered in very select cases with evidence of severe degeneration on enog early on.
Okay. Moving on from Bell's, trauma is the next big category.
Yes, second most common cause, temporal bone fractures, as mentioned. Transverse fractures are more likely to cause immediate complete paralysis and often need surgery.
What about penetrating injuries?
Wounds medial to the lateral canthus usually don't need primary nerve repair due to the dense branching. Spontaneous recovery is more likely. But if you have a significant temporal or marginal mandibular branch injury, peripherally causing major weakness, repair is often recommended as spontaneous recovery is less reliable there.
And if you can't repair immediately,
Tag the nerve ends. Makes finding them later much easier.
tumors are always a concern too.
Always. Presentation very sudden, slow, complete, incomplete, maybe even with hyperkinesis. Be highly suspicious if you see slowly worsening weakness over 3 weeks, abrupt weakness with absolutely no recovery by 6 months, or associated twitching or spasms.
What kinds of tumors?
Primary facial nerve tumors, like schwannomas, parotid malignancies, acoustic neuromas compressing the nerve, other CNS tumors, skin cancers spreading perinaturally, metastases, cholesteatoma, even hemangiomas.
Viral infections besides the suspected role in Bell's.
Definitely. Varicella zoster, VZV, herpes simplex, HSV, Epstein-Barr, EBV. Ramsay-Hunt syndrome is key here. VZV reactivation in the geniculate ganglion.
What are the features of Ramsay-Hunt?
Facial paralysis, often quite severe, plus significant ear pain. And that characteristic vesicular rash in the ear canal accounts for maybe 12% of facial palsies.
The treatment.
Usually combination therapy, prednisone, plus an antiviral like acyclovir.
And we shouldn't forget iatrogenic causes.
No, sadly. Post-operative injury happens. After acoustic neuroma resection is a classic example. Direct trauma, thermal injury, devascularization, swelling, even herpes reactivation post-op.
Okay, that covers unilateral well. What about the rarer bilateral facial paralysis?
That's rare, maybe 0.32% of cases. The top associations you need to think of are Lyme disease, tick-borne Borrelia burgdorferi infection, and HIV infection.
Right, and recurrent facial paralysis.
Mulkerson-Rosenthal syndrome is the classic one to know. That triad, recurrent facial palsy, non-inflammatory facial swelling or edema, and a fissured tongue. Cause is unknown, maybe hereditary. Palsy can switch sides. Treatment is usually conservative, but decompression might be considered if it's severe.
Can Bell's palsy recur?
Yes, it accounts for about 10% of recurrent cases.
Finally, let's touch on pediatric facial paralysis specifically. Causes differ.
They often do. Congenital or developmental things like Moebius syndrome, Chiari malformations, syringobulbia, idiopathic Bell's occurs, trauma blunt, penetrating, iatrogenic, even birth trauma. Infections Lyme, VZV, HSV, EBV, Haemophilus influenza, neoplasms, cholesteatoma, schwannoma, parotid tumors.
Is decompression recommended in kids?
Generally not for acute pediatric facial paralysis. That's an important point.
Tell us more about Moebius syndrome.
It's congenital, characterized by inability to abduct the eyes, so sixth nerve palsy, either unilateral or bilateral, plus facial paralysis, again unilateral, bilateral, complete, incomplete. May have other cranial nerve issues, limb defects, muscle issues, micrognathia, sometimes mild intellectual disability, thought to be a primary CNS developmental defect. Treatment often involves free functional muscle transfer later on.
Any other key pediatric conditions?
Hemifacial microsomia, that first and second branchial arch issue, can have associated facial palsy in some cases.
Oh.
And congenital unilateral lower lip palsy, CULLP.
CULP.
Sometimes called asymmetrical crying face, thought to be from an intrauterine issue around week 5. Resting tone is normal, but when the baby cries, the marginal mandibular nerve dysfunction shows up as asymmetry, often associated with other major congenital anomalies, maybe 75% of the time.
Okay, that covers paralysis well. Let's switch gears slightly to facial dyskinesias, involuntary movement.
Right, dyskinesia just means involuntary, uncontrollable facial muscle contractions, unilateral or bilateral.
What are the main types?
Hemifacial spasm is a big one. Usually starts middle-aged or older, begins around the eye, orbicularis oculi, then progresses downwards. You might see a tonus phenomenon, sustained contraction.
Cause.
Usually vascular compression of the facial nerve root entry zone at the brainstem. Treatment can be microvascular decompression surgery,
What about essential blepharospasm?
more common in older women. Involuntary spastic eyelid closure. If it involves the lower face to grimacing tongue protrusion, that's called Meage's syndrome.
Treatment for blepharospasm?
Options include selective neurectomy, excising some periorbital muscles, or botulinum toxin injections, which are often very effective temporarily.
And then facial myokymia.
That's more of a continuous undulating sort of worm-like muscle contraction. EMG shows characteristic discharges.
What causes myokymia?
Can be seen in multiple sclerosis, polyradicular neuropathies after radiation, or with peripheral nerve injury.
Okay. Now let's move to evaluating a patient with facial paralysis. History and physical are key.
Absolutely. History. You need onset details, sudden, gradual, duration, progression getting worse, better, stable.
And on examination.
Look systematically.
Yeah.
Assess for that compensatory contralateral hypertonicity, the good side, working overtime, which can cause an S-shaped deformity. Check the eyelids meticulously. Laxity, retraction, ectropion, leg ophthalmos, incomplete closure.
Corneal exposure risk.
Huge. Check for exposure. Also look for bactosis, excess skin, erythema tearing. Assess Bell's phenomena, the eye rolling up and out on attempted closure. Check corneal sensation. If it's down, get ophthalmology involved urgently.
What else on exam?
Corneal light reflex for alignment. Visual acuity. Schirmer's test for tear production. Eyelid closure rate and how much excursion there is. Forehead, skin, and eyebrow position symmetry. Look for maxillary hypoplasia. A negative vector globe, prominent relative to cheek, increases risk of lid problem.
Functional issues.
Check for nasal obstruction. Nasal valve collapse from nasalis paralysis. Assess speech. Drooling, oral incompetence. Points to orbicularis oris weakness.
How do we grade the paralysis severity?
The House-Brackman scale is the most common gross scale. Grade of Verne is normal. 5 is complete paralysis. It's useful, but subjective.
Are there more objective scales?
Yes, scales like Burr's fish or Sunnybrook aim to reduce subjectivity, especially looking at synkinesis. There are many others too, but House-Brackman is the one most widely recognized for general reporting.
When do we need further diagnostic studies?
Well, for classic Bell's palsy, you might observe for about 3 weeks before a big workup. But if the presentation is atypical or it's not resolving, you need tests.
Tests for the cause.
Right. Serology for things like syphilis, diabetes, viral titers, maybe radiographs looking for bone destruction or ISE widening. CT is great for bone detail fractures, tumors, fallopian canal issues. MRI is better for the nerve itself and soft tissues, looking for inflammation or tumors.
And what about tests to predict prognosis?
Electrophysiology helps here. Nerve excitability test, NET, measures the threshold stimulus for a twitch. Maximal stimulation test, MST, looks at movement with a stronger stimulus. Both are a bit subjective and have limitations.
What's the gold standard prognostic test?
Electroneurography, ENOC, is generally considered the most accurate. It measures the compound muscle action potential after stimulating the nerve. Significant degeneration, say 75–95%, within the first couple of weeks might suggest considering decompression in selected Bell's cases.
And EMG.
Electromyography looks at the muscle activity directly. It takes 2–3 weeks after injury to show denervation changes like fibrillation potentials. Fibrillations are bad, mean denervation, but also good, as they show the muscle is still viable and could potentially be reinnervated. EMG is very useful for late prognosis and complete paralysis.
Are topographic tests still used much?
Less so now, with better imaging and electrophysiology. But tests like Schirmer's for tearing, stapedial reflex testing, and taste testing can theoretically help localize the lesion along the nerve's intertemporal course.
Okay, so we have the diagnosis and prognosis. What are the overall goals when we consider surgical treatment?
The goals are really multifaceted. Number 1 is corneal protection. Then, restoring sphincter control, oral, nasal, ocular to help with drooling, breathing, eye closure, achieving a normal resting appearance, symmetry. Getting symmetry back during movement, both voluntary and involuntary, especially a dynamic smile, balanced emotional expression, and critically, doing all this without causing loss of other important functions.
That leads perfectly into treatment planning. How do we analyze the problem to decide on the best approach?
It starts with a history again. Was the nerve cut, or is it intact? Is the paralysis complete or incomplete? How long has it been paralyzed? This affects muscle viability. Patient's age, health status, eye status, does it need urgent protection? And crucially, patient expectations.
Matching treatment to the patient's main concern.
Exactly. Is it function they care most about, or the aesthetic appearance at rest? What aspects are realistically reconstructible? You need realistic expectations about reinnervation. Especially after about 3 years, muscles might not be viable then, though EMG fibrillations can sometimes suggest otherwise.
What are the broad categories of treatment?
We think about reinnervation strategies, dynamic reconstruction using muscle transfers, and static reconstruction for support and symmetry. Often, it's a combination.
Let's start with reinnervation. What's required for this to work?
You need viable muscle fibers, working motor end plates, and a nerve conduit, either the original nerve sheath or a graft that's not blocked by fibrosis.
Simplest case.
Primary nerve repair. If you can bring the cut ends together without tension, that's ideal. The more proximal the repair, generally the more potential for synkinesis later.
What if there's a gap?
Then you need an interpositional nerve graft. Sural nerve from the leg is common. Great auricular, medial, or lateral, antebrachial, cutaneous, or other options. Remember, axons regrow about 1 millimeter a day.
What if the proximal nerve stump isn't available on the affected side?
Then you might consider a cross-facial nerve graft. You borrow nerve signals from branches on the unaffected side, using a graft, usually sural, tunneled across to connect to the distal stumps on the paralyzed side. Needs viable distal nerves and muscles.
Is that 1 or 2 stages?
Can be either. 2 stages involve placing the graft, letting axons grow across, then connecting to a muscle transfer later. 1 stage combines it with a free muscle transfer immediately. There's also the babysitter idea, using part of the hypoglossal nerve temporarily while the crossface graft grows in.
What about nerve crossover procedures?
This is also when the proximal ipsilateral stump is gone. But distal nerves muscles are okay. You connect the distal facial nerve directly to another motor nerve.
Which nerves are used?
Hypoglossal, CNOA, is the most common. Masseteric nerve from V3 is increasingly popular. Others used include glossopharyngeal, anarchage, spinal accessory, phrenic, even C7 root, cervical plexus motor branches.
Pros and cons.
Powerful reinnervation source, only 1 suture line needed, but you sacrifice the donor nerve function, which can be significant. Often results in mass movement or synkinesis grimacing when you try to move the donor muscle.
Let's focus on the hypoglossal transfer.
Very common, especially for immediate reconstruction during tumor removal. Gives excellent resting tone and appearance, good eye protection with voluntary effort, but typically no spontaneous emotional expression.
Main drawback.
Ipsilateral tongue paralysis and atrophy. Most tolerated okay unless they have other lower cranial nerve problems, but it's a definite downside. Also, that synkinesis involuntary facial movement when moving the tongue.
Is there a way to mitigate the tongue issue?
The hypoglossal jump graft, or partial 12-7 transfer. You only use part of the hypoglossal nerve, trying to preserve some tongue function. Considered for patients with other cranial nerve issues or those unwilling to accept the full tongue deficit.
Any other reinnervation techniques?
Direct neurotization. Implanting a nerve directly into a denervated muscle, sometimes used to augment weak areas like blink or smile without disrupting existing innervation patterns.
Okay, moving to dynamic reconstruction. When is this indicated?
When the original facial muscles are gone, or too atrophied to be reinnervated effectively, or sometimes as an adjunct to provide new muscle bulk or for myoneurotization. Regional muscle transfers are one option.
Like temporalis or masseter.
Exactly. Temporalis transfer is probably more common, greater excursion, more adaptable. You can transfer the muscle, often with fascial extensions, to power the eyelids, nose, lips. Using the temporalis tendon can help avoid temporal hollowing.
And masseter transfer.
Gives motion to the lower face. Usually involves splitting the muscle and transferring slips to the lips and commissure, sometimes done acutely during periodictomy if the nerve is sacrificed.
Any others?
A gastric muscle transfer using the anterior belly tendon transferred to the lower lip can help with marginal mandibular nerve palsy.
What's the next step up for dynamic reconstruction?
Free functional muscle transfer. This is when facial muscles definitely won't work after reinnervation attempts. You bring in a muscle from elsewhere with its own artery, vein, and motor nerve.
Like the gracilis muscle.
Gracilis is the workhorse, yes, from the inner thigh. You transfer it, hook up the vessels microsurgically, and connect its nerve to a power source on the face.
What nerve source?
Either a cross-face nerve graft placed previously, 2-stage approach, or sometimes an ipsilateral source like the masseteric nerve or even the spinal accessory nerve, 1-stage approach.
Advantage of free muscle.
Provides healthy, vascularized muscle. Can be positioned for multidirectional pull, aiming for a more natural smile. Requires significant expertise and resources.
Okay, finally, static reconstruction. When is this the main approach?
When dynamic reanimation isn't possible or indicated, maybe the patient is elderly with comorbidities, poor prognosis for recovery, or massive defects after cancer, failed previous attempts, or just long-standing muscle atrophy.
What are the goals here?
Primarily corneal protection and achieving reasonable resting facial symmetry. Also addressing functional issues like drooling, nasal airway obstruction, speech problems caused by lack of support.
Can you give some examples of static techniques?
Sure. For the brow, various brow lift techniques, different incisions, fixation methods to lift a ptotic brow. For the upper eyelid, lubrication is key. Gold or platinum weights can help closure. Tarsorrhaphy, sewing lids partly shut, is usually avoided as primary treatment. Palpebral springs or temporalis slings are options too, maybe blepharoplasty for excess skin.
Oh, or eyelid.
Ectropion is common, corrected with canthoplasty or tarsal strip procedures to tighten the lid laterally. Medial issues might need specific approaches. Skin grafts, if it's cicatricial, lots of support needed post-op.
Midface and nose.
Midfacial ptosis can be helped with suture suspension techniques. Nasal valve collapse causing obstruction might need suture suspension, fascial slings, or even formal rhinoplasty.
And the oral commissure, drooping corner of the mouth.
Fascial slings are common here, often using fascia lata from the thigh, pass from the zygomatic arch area down to the commissure to lift it. Multivector suture techniques can also provide support.
Lastly, let's touch on complications, particularly after re-innervation attempts.
Synkinesis is the big one. That unintentional movement like the eye closing when you try to smile.
Yeah, causes it.
Aberrant nerve regeneration. Axons grow back down the wrong pathways, innervating muscles they weren't originally meant for.
How do you manage synkinesis?
Physiotherapy. Free functional muscle transfers offer the best potential for restoring dynamic function, like a smile, but they require significant post-operative physiotherapy for success.
Excellent summary. And maybe a final thought. Considering all this complexity, nerve regeneration, muscle health, surgical options, what does the future hold? What are the most promising directions for achieving truly spontaneous, natural-looking facial reanimation? Something to ponder.
A very pertinent question indeed. Lots of ongoing research in nerve guidance, targeted reinnervation, and refining techniques.
Thank you for joining us for this focused discussion. We hope this helps solidify these key concepts for your exams.